All right, you should be able to see the slide, correct? Patient history on top. Confirm with me because I can't see you.
Yes.
Great. Okay, now this is kind of what I was normally going to do Saturday morning, something where I'd cover, but I wanted to get into it a little bit now so that Saturday morning it may just give us a little bit more time, where we're still going to do safety. But I figured if I can kind of get some of this lecture done now, then it's going to save us some time for tomorrow. And again, Jim has great safety stuff all throughout this module. So between his lecture on Horner syndrome, safety considerations, quality stuff, the IFOMPT paper is a classic one to do because we're basically the AOMPT Fellowship is a member organization of IFOMPT. They put together this nice paper. It's really considerations. And what they find is that when we look at somebody and we're really looking at vascular pathology or dysfunction, this are kind of the two big things we're thinking about when we're looking at, we're thinking about manipulating somebody, dissecting stroke, and again, because the most common causes of recent trauma is, for instance, significant risk for dissection. And the problem we run into with dissection is that even as we get into our special tests, and we're going to go into doing cranial nerve and position testing during the course, but with the dissection, you're not going to get the cranial nerve signs because there's been no clot that's been thrown per se. So, when you're looking at a dissecting stroke, it's the fact that the stroke has happened. And that's when you're going to get positive cranial nerve tests. You're going to get dizziness, headache, those usual things. With somebody with the dissection, we may just have neck pain and headache, which again, we're then looking to differentiate the neck pain from the headache, but it never really fully excludes the fact that this person may have a vertebral artery dissection or a carotid artery dissection. It can be a little bit trickier to pick up. Jim talks about in the video, like, okay, with the carotid artery, injury, trying to differentiate that from sternocleidomastoid by, again, location of symptoms. One is the anterior neck. And then also, he mentioned maybe even just a compression or pinch test of sternocleidomastoid as a way to, okay, the sternocleidomastoid is not sensitive, then it may sway you to think that, okay, do I think that this may be more carotid artery because the muscle itself is not sensitized. But within there, it's still not like an ironclad, test to say, okay, well, sternocleidomastoid is now tender to palpation. It must be the muscle. But it certainly kind of strengthens that thought process of a acute muscle injury. So these dissections are going to be very, very tricky in what to do. And I think sometimes when you do see these strokes happen post-manipulation, one, it's usually more violent rotary techniques, unlike what we're going to do in this class. And two, it's like you have this dissection in the embolus, and then you're putting enough vigor through the vertebral artery to then dislodge it. So it's often, something in that nature is creating that problem when it's a dissection. So, things that we can tell, recent trauma, vascular anomaly, you're going to have no real warning on, other than the fact that they start showing signs of blacking out and falling, cranial nerve signs. Unless you're getting a history of those things, you're not really going to get much of a warning sign on vascular anomalies. Now, that person does come in, and let's say we're in a clinic where, okay, yeah, we're seeing people who are obese, high cholesterol, smokers, car accident, neck pain. Then, I got to kind of weigh as I get in here is that, here are these increased risk factors for this individual, to have a dissection or a problem. So as I get into my treatment, it's something I always want to weigh. Like I'm lucky. I'm in a setting where I see fairly healthy, active individuals. But that said, I can say over the last 7 years, like 3 of the women I've known here have had, basically dissecting strokes. And they're all been about in their mid to late 40s to 50s, which is not it's also kind of a common age to see some of these vascular anomalies crop up, whether it's an aneurysm or these dissections or a stenosis of one of the arteries. It's not an atypical age. So, we have trauma, we have past medical history, but then I also weigh, okay, where is this individual, in that span? I can't not manipulate every 46-year-old female because there have been 2 or 3 that I've seen happen. But it does kind of make me think about the technique that I may use and what position the vertebral artery is in when I do it. So we'll chat about that. And as we practice, we'll modify techniques to kind of think that, okay, I'm feeling pretty good, that I'm not putting unnecessary force through the neck to achieve the result I want. I'm able to generate sufficient force through the neck, but they won't be the big fancy rotary manips, because quite honestly, if I can get the joint to free up without the rotary manip, it's going to be a much better outcome. You know, common symptoms you're going to get with, if you look at this, whether it's a dissecting stroke or non-dissecting stroke, it's going to be, your headache is going to be kind of your number one. They're going to put, with the dissecting stroke, of course, you're going to expect, now that you kind of progress, stroke, you're going to have potentially paresthesias, other problems. You see vestibular disturbances being high on both of these. It's interplacing with there. So when we get into there, we are going to, you look at cranial nerve testing. You do have a patient with a neck pain and headache. The cranial nerve testing, if you're having a visual disturbance, lack of coordination, dizziness, most of the times these things are going to cross over multiple cranial nerves. You are not going to see like a single cranial nerve on the left-hand side be impacted with somebody who's having a vascular event. You're gonna go across multiple cranial nerves just because of the multitude of connections that occur and how they all interplay, how the vestibular system interplays with the visual system, even into the spinal tracts. So it's usually, if you're going to see those, it's not going to be a non-subtle finding. You're going to have multiple cranial nerves. And that's kind of why I also put in like what happens when you see one cranial nerve, what may be the case. And I thought about Chan when you saw this, because he had mentioned that he may see the population that may not be, maybe the exact opposite population I see. They may be like, the walking risk factor. So, if somebody has a unilateral ocular motor or dysfunction, or say a lateral gaze tracking problem, well, we see one motor unit get knocked out in one nerve. It's typically vascular. So, and like in the eye, there's multiple areas where people with these same risk factors, hypertension, high cholesterol, history of smoking, you get vascular ischemia in the blood vessels which supply some cranial nerves. So it'll give you a kind of a common presentation. And we'll talk about the different presentations that may occur in those individuals. Again, there's a chance you'll see more of a better chance of you seeing one of those than there probably is you bumping into somebody who's having a VBI dysfunction when you put them in extension rotation, you're going to see loss of cranial nerve function. So I included that in the manual. We'll see if we get into it or how deeply we get into that. In here, it's, as I talk about, patient history, usually establish hypothesis related to the vascular pathology. And it really is about clinical reasoning. It's really taking into account is what are all the facts I have on this individual? What are the statistics I know? And then where do I gauge my risk? And what you'll see when we get into it, that's where you'll see Jim with the modified declines test of saying, okay, let me progress this individual through certain positions to try to see if I can tease out that when I can work slowly from pure rotation to rotation extension, that I see that, okay, I see no cranial nerve signs, which we're seeing over here in the signs column, and that I feel comfortable progressing into a manipulation on this individual. Because I really want to be kind of sure about it. And many times if I have any other questions that the unforeseen, like there's something still I don't like about this person, like, do I feel like whatever it is their pain, it just doesn't feel like it's purely musculoskeletal, and they have some of these risk factors for a dissection that they haven't stroked, then I certainly back off. I think you'll see that Eric and I will talk about, and he'll teach some of the courses too, that, generally I'm pretty conservative for the first 6 weeks, because that's where you find that I think upwards of 30% of car accident patients can have a dissection or an intimal tear, that goes undiagnosed or unseen. So with that in mind, I'm a bit more conservative with when and what I'll do, but I will use all the biomechanics that we talk about to treat the neck. I just may not do a very forceful thrust manipulation. I may choose to say, how can I get this joint to move better the way I want it with applied biomechanics? And we'll chat about that in treating the acute patient that you may not want to manipulate with that. Risk factors for dissection vascular events. As you see, trauma is number one. And this is that Bayesian theory that, I think, okay, well, if I have a risk for this, where am I setting my pre-test probability? And I like this because here it kind of sets my pre-test probability. This person comes in here with a known vascular anomaly. of, they have a 39% increased risk of vascular events. And not somebody I'm going to be jumping up and down to do a lot of vigorous neck manipulation on. Smoker, I will treat. Again, a 55-year-old smoker with multiple risk factors, I'm going to be a bit more conservative. 23-year-old smoker, I will probably gauge it down a bit based on time. So within all of these, it's not like any one of these says, oh, they have high cholesterol, I'm not going to manipulate their neck. It's got to be gauged with the additional information I have, and then deciding whether, okay, is this really manipulation appropriate, or should I choose an alternative technique that may achieve the same result? So with these risk factors, as we see here, it's just kind of good to know. We all think of the car accident, or maybe, a head trauma, post-concussion, if it's a sports injury, less common for me to think about that one, but, this would be what I think of. It's just, what are these risk factors that are in here? And then patient population. Here, risk factors for non-dissection vascular events in there, arterial ischemia. So your current or past smoker really is your high one there, and your hypertension. So if you're looking at somebody who's more prone to having ischemic or some type of stroke event, it's your classic, basically this is the risk factor for many physical disorders that you're going to see. It's not exclusive to stroke. Oral contraception's in there. If you're thinking that, that earlier 28, maybe 40-year-old female, long history of oral contraception, that may be something that you just think about. And again, maybe it doesn't stop me from treating the neck. Maybe that just grades me down in my approach to start with a more conservative approach first and work my way up versus, just going right for it and knowing that I can manipulate this and I fix it. I may just select one of the alternative techniques, and we can chat about that on the weekend of which technique I would choose if I felt like I wanted to be more conservative with that 32-year-old female. And go through, you can read those. All right, symptoms reported. Dissecting events, headache is by far the biggest one we're going to get. And that's where Jim and some of the videos too, I think the algorithm, I pulled it out. I think I put some of the algorithms into the manual. We'll review them either today or we'll get to them on Saturday. Is looking at this. Headache is number one. So what we get caught with is differentiating the headache and the neck pain, because they're both occurring at a high rate with these individuals. Anybody who has a neck trauma, the dissections, you're going to have these. So, anterior neck pain may be more indicative. Is it more of a carotid or injury, or could be long, anterior longitudinal ligament? It could be longus coli capitis. Anterior neck pain can be multiple of things, but again, carotid artery is certainly injuries in there as well. Posterior neck pain, headache, Ramsden sign, headache coming around, the classic there. It's, we have to be able to can we differentiate in some way to couple the neck pain or uncouple the neck pain, as Jim talks about. Again, being coupled certainly helps it out, because when the neck pain is coupled, it's easier to kind of say, okay, these are coupled things. It probably reduces maybe the likelihood that it could be, like a bleed that they're talking about there, or some event has happened. But still, with a vertebral artery injury, you can't completely decouple the two events. Visual disturbance, that's kind of where doing cranial nerve exam kind of key, because that's where you're going to look at the oculomotor tracking. You can see there are any abnormalities in oculomotor tracking. Again, you're looking at mostly the three cranial nerves, which will control that. And, paresthesias, upper limb, certainly if they have a paresthesia in the upper limb, my first thought is that, hey, I can't wait to get in and manipulate this neck. Yeah. Dizziness. With dizziness is what we're going to look at determining is what type of dizziness do we have? Is vertiginous or non-vertiginous dizziness? It's kind of the first dividing line. Is okay, is this dizziness that may be coming from the peripheral system, or do I have a centrally driven dizziness? The peripheral dizziness would indicate, okay, some type of maybe labyrinthine injury, do I have BPPV, something else that may be occurring in the peripheral organs, versus a central integration dizziness, a disequilibrium, the sensation of moving or being unsteady, maladembarkment, something along those lines would indicate more of a central dizziness. Certainly any type of paresthesia in the face or lower limb, because then, we're looking at, do we have a central problem, or do we actually have cranial nerve involvement? So with the dissections, and these are often dissecting strokes, these are the symptoms you'll get. If you have a dissection, you're probably going to more have the first two. You may have a headache, neck pain, and I believe dizziness may be in there down there as well, just because of just some of the upper cervical integration of the dizziness centers and cervigenic dizziness. So you may get some of that as well, but not all of these things if it's been a dissection that is not turned into a dissecting stroke. And reported symptoms in non-dissecting strokes is going to be, headaches, number one again. This one is a bigger stroke, generally or vascular, so you're going to see paresthesias, upper, lower, face, neck pain, dizziness, down a little bit lower in these because it's not really been from a dissection that's occurred in the neck or the vertebral artery. And signs of a tubular insufficiency or injury, you're looking for these things. Certainly, you're looking at probably the upper motor neuron type things. When you're looking at unsteadiness, ataxia would be one. Dysphagia, dysarthria, aphasia. Really here you're looking again cranial nerve function, higher center function. Nausea or vomiting, central integration, facial palsy, dizziness, disequilibrium, ptosis, loss of consciousness, confusion, drowsiness. So if you're having a vertebral artery event, you're going to have probably not just one of these things. You're going to have a multitude of these things because you have overlapping regions and overlapping communicating areas. So it's not as if we're going to go in there and think, hey, listen, I only have dysphagia. That's the only thing I see. That it may be a stroke, maybe in that one small center. But if we're getting a vertebral artery injury or occlusion, then we're going to have multiple areas of these things. Unsteadiness and ataxia may be number one, but we're going to have a few other things likely coupled with it. I don't expect to see things in isolation. So again, internal carotid artery, you're going to see a little bit difference. You still have weakness, facial palsy, dysphagia, dysarthria, aphasia, unsteady gait. So we have fairly similar things. At this point, once you have any of these things going on, you're probably sending this individual off. So I'm not going to spend the next hour trying to kind of make a chart here and determine how many of these they have and to what degree. I think one of them or several of them would probably be two of them, where it can be plenty enough for me to kind of move this patient on, in any meaningful fashion. Nausea and vomiting a little easier, harder to tease out, but again, you're probably not going to see nausea and vomiting in isolation. Get into non-dissecting, events in the arteries. Again, most of the time what you're going to see is there at that point when you're talking about stroke, you're looking at, weakness in the limbs. Upper limb is affected differently than the lower leg. The lower leg tends to recover a bit differently just in kind of how the body and the brain map, the collateralization of nerves are done. That's why even in these stroke events, it's harder to recover fine upper motor than it is lower extremity. And they see that in stroke patients when even they look at rehabbing programs. Getting some of that fine motor, the fine control in the upper extremity can be more difficult than the lower extremity based on, I can't remember the exact pathways that overlap or do that, but I think one favors gait over upper body propulsion or the fine motor system. And I think they often talk about, I think what it is that I'll check out for the class. It's the vestibular spinal tract in some ways, or the vestibular bulbar tract creates the tone in the upper extremity more so, and that's why they may have more problems long term in the upper extremity as far as control. But I'm digressing. Okay, this case is in your work. I usually cover it during the class, but let's dig into this a little bit here. And from here we have a 46-year-old female supermarket worker who presents to physical therapy with left-sided head occipital and neck pain described as unusual. She reported a 6-day history of symptoms following a road traffic accident. Now, this is not an atypical individual. This is what we're typically going to see. And I read this history right to here. I am not thinking, oh, this person's having a stroke right away. The unusual symptom, again, is odd, but it's probably not enough to trigger me right here. 46-year-old female. I think the average age in the U.S. is 50 for some of these dissecting strokes or ischemic events or aneurysms, but I think it's like 40. I know it's actually 46 or 47, like in Saudi Arabia, because one of the Saudi princes gave millions of dollars to Hopkins to study stroke. And that's what their problem was that they see a much lower stroke rate, whether it's smoking or lifestyle, a much higher stroke rate at a younger age. Here we have symptoms were progressively worsening. And that's kind of, as we look at these case studies, you think about, I have worsening symptoms over 6 days. If I'm hearing that, then that's my first flag that I'm going to note that, okay, I have worsening or progressive symptoms over 6 days is going to give me a moment to pause. And really kind of then we're going to kind of make sure we have a good screen. Now I want to know, okay, maybe I'm going to make sure I know, okay, does she have the information on all these other risk factors? Not that it's the end all be all in this decision making, but it does start to weigh me to think, okay, she's a smoker with high cholesterol, then okay, it's going to certainly push my pretest probabilities into a category where, okay, I want to be really sure that I don't have something going on, given she's the right age, she has some risk factors. Pain was eased with rest, which is good. It tells me that, okay, it could be back in the mechanical or musculoskeletal side of it. And she's reported a previous history of road traffic accidents. Now, hearing that, I can also think that if she's had prior neck injury, if I'm thinking from the musculoskeletal world, yeah, there's a chance that if she had prior neck injuries that, yeah, there should be some atrophy of multifidi in this case. And they could be fatty infiltrates and fibrosis, decreased stabilization. She could have abnormal firing patterns. What you'll see, again, some of the superficial muscles will become hypertonic. So with this one, my thought process would probably go to, yeah, there's been prior traumas, but she's not reporting any events. But well, in my mind, I'll know is that, okay, there's maybe an inclination for some of these musculoskeletal findings that may be chronic. And the next sentence kind of tells me what I talked about earlier, the past medical history, including hypertension, high cholesterol, and maternal family of heart disease and stroke. Those right there kind of, again, it raises that pretest probability. She's got a couple boxes there that are already putting her into a risk category for this individual from what we saw in the earlier section. Here we go. We have cranial nerve testing. We're testing 8, 10, and 9 were positive, and resting blood pressure was 170 over 120. 2 days after assessment, the patient was reported an onset of new symptoms, including feeling like I may be sick, throaty, and feeling faint, especially after performing prescribed neck exercises. Anybody have a problem with this, Chan? What are you thinking about this case right here where it sits right now? So she's feeling throaty and faint, especially after performing prescribed exercises.
Yeah, that right there was the red flag to me when it says reading the previous history of road traffic accidents. The first thing I thought, oh, maybe she's, strained some scar tissue or whatever, the fatty intrate. But when somebody starts saying when they're moving and they start to feel sick or throaty or feels faint, that's like it's ready to get somewhere else.
Yeah. And what I always thought was funny with this case too was the fact that she had positive cranial nerve tests and they gave her exercises.
Yeah. The resting blood pressure of 170 over 110, you start going, maybe they got bigger issues than just neck pain. That needs to.
Yeah, it's exactly. It's like, you get the blood pressure, you have a few other things going on here that would do it. Anyone else? Patrick, any thoughts on this case? When did you start thinking what? Again, you don't have to know it all right away. It's just at what point did you start feeling like, okay, there's something off here?
I was thinking when we had the positive cranial nerve tests, even though she has a history of hypertension, 170 over 110 is pretty concerning still.
Yeah. I know that's the interesting point here because we're going to spend some time, with cranial nerves and, again, that person here, like, who knows, maybe bump into this individual and she has, basically her abducens is impaired, unilaterally. It may be vascular in this person. She could, certainly if she added in some diabetes there. It's my friend of mine's an ophthalmologist and was hanging out with him and said, hey, what do you see with the cranial nerves? And he went over basically the vascular thing is what he sees the most. and basically get ischemia of the blood supply to the outer part of the cranial nerve, and it'll knock out one of these functions, and it can recover usually in 6 to 8 weeks. But the fact that she has 3 cranial nerves that were positive and the blood pressure like that, and that right there, again, in our case, would be enough to kind of move them along. Feeling sick and throaty and faint is also pretty good. If he was not really making much of it, maybe he thought, okay, maybe I'm not reading this right. Maybe this is just a vascular thing because she has these predispositions. We overlook it. That's why once you get to the feeling, sick, throaty, and faint, that certainly should put you over the top. And again, once you get in here, 2 days after this, you report stronger feeling of nausea, loss of balance, swallowing difficulties, speech difficulties. Now she looks like one of the charts above. She's basically ticking up, maybe, 8 or 12, 8 or 7 of the boxes that we see. So this person then kind of maybe progressed from the dissection to the stroke. But there's probably already something going on because she was positive with the cranial nerves. Again, trauma together with classic, she's kind of a classic distribution for vertebral artery somatic pain, which was worsening. And it's going to be really, really hard to tell vertebral artery somatic pain at times from, musculoskeletal pain and inflammation. Without, having a good understanding of, at least in my mind, I'm aware of these lists that we've covered above, and I have a way of screening for it, whether it's, I'm going to do cranial nerve dysfunction, maybe look at blood pressure. Do I have the history? Do I get a sense of in these cases where these people may not be the healthiest? Can I account for these things and everything that we're doing? So, and again, and what the research tells you is that you probably can't tell. It'd be easy if you out there justifying you shouldn't do any of this because it doesn't tell. It doesn't, you don't really know. It's not really positive. They could have a dissection and you're not going to pick it up. So we shouldn't do any of these pre-manipulative testing and holding because it doesn't give you anything valuable. But like in cases like this, it does, because what you don't want to do is miss the easy things. So you don't want to miss an easy thing that, okay, well, if I looked a little bit closer, she has enough history that I don't want to do this. Or I pick up that subtle detail. These symptoms are worsening. And, oh, look, there is a like cranial nerve deviation here that crosses into speech or uvula not thing. Maybe the tongue tracks to the side and they have ocular dysfunction. So I can put these things together. And so having a good cranial nerve test, being able to evaluate this, understanding I can look at blood pressure, I can get history. You can have the complete picture in your mind that I've done everything I could for this person. One, as a patient, but then 2, that, okay, I'm going to go and treat the neck. I feel pretty comfortable with these variables of where I am that I'm going to go into the neck and I'm going to do a treatment. Or this person has some of these variables that are risk factors. They have a oncovertebral joint, which feels a little sticky. And I really feel like if I work on that, and this is mechanical pain, I can loosen it up. But, you can never 100% rule out that there's maybe a pathology there. So how do I get that right oncovertebral joint to get an inferior glide, but I don't want to use a forceful manipulation? We'll cover that and we'll practice that during the class. But that's where we want to kind of be, is that in your mind, you've gathered all the information. You just haven't kind of skipped over some things and thought, well, we can't really tell if you have something, so I'm not going to pay attention to anything, and I'm just going to blindly treat your neck, especially in a case of this thing and this nature. And it's kind of a classic one too. It's a friend presents to physical therapy with a sore neck and unremitting headache. The individual complains that they think their neck is out. They ask if they can have their neck manipulated to put it back in. The headache at present was present for 3 to 4 days and getting worse. He noted that the pain was unrelieved by medication, which may indicate that, okay, it's not inflammatory, and it appears to be mechanical presentation. Without taking a full history and carrying out a physical examination, physical therapist goes ahead and manipulates the neck. The result was an individual experiencing numbness and paralysis in the left arm and hand. So I never do, the moral of this one is never do friends a complete favor without checking them out. Like whenever I see somebody I know, even somebody, funny enough, somebody I like, I try to make sure that I always reset, and I try not to take like a shortcut just because I know them. especially if I haven't seen him well. If I see him regularly, then I will shortcut it. But if it's somebody there, it's like, 'cause when you take that shortcut or you do that quick thing without that extra piece of thinking in it, that's where many times you always hear the mistake happening, somewhere. You're doing your friend a favor. You're doing something. A buddy of mine's a radiologist. He always said he never wanted his friend to read his study. He always wanted somebody who didn't like him to read his study, because he would give him the truth. His friend may, sugarcoat it and give him a favorable read. So it's the running joke he always had. And it's kind of like, I think about it when I do this, is that, okay, I know this individual, so let me do some bias correction to make sure that I'm not cutting a corner. If I'm going to go and manipulate their neck, am I cutting the corner, or do I need to look at one or two more layered things that may be going on?
When Miss Gray comes in, and you remember to ask her
investigation. So synopsis: investigation of post-incident identified an intramural tear of the vertebral artery. The key issue with this case is that the presentation was fully assessed through the detailed history and physical examination. Again, the fact that he may not have been able to pick this up in the history, but the fact that, okay, there was no examination done on him to see, okay, were symptoms worsening? Did I in fact get some of these symptoms or get dysesthesias or anything that was odd when I did position testing with the neck? Doesn't helps. The fact that history is worsening. So, like, this is something that's very common. You'll bump into this. It's easy. And so I always like this one because it's that nice reminder that what I need to do when I look at somebody, especially somebody I know, is not make the shortcut. If it's the 6 o'clock patient and I've been working for 11 hours, I have to kind of reset myself and kind of, get myself recentered and say, okay, this isn't something I can now breeze through. This is something I got to sit down and make sure that I'm methodical about, and not just, kind of cut corners because I'm tired. So I'm usually trying to be very careful, knowing myself where I am in that given day, and making sure that I'm in the right headspace to make sure that I'm not kind of jumping to something just because, okay, I can manipulate this neck, fix this rib, and I can be on my way and they'll be, 60% better. I just want to take into account, where are they in space? Another case we'll do is a 42-year-old accountant presents with physical therapy with 5-day history of unilateral neck pain and jaw pain, as well as a temporal headache following rear end motor collision. This one, this is probably somebody that a lot of us see. You're going to see this person with this headache. The jaw pain's a little unique. You'll also see jaw pain, but I would flag that a little bit and try to get a little bit closer with that one. And temporal headache. You have rear end motor collision. So we have a logical mechanism of injury. And, so it's not what we see, but the jaw pain is something I may want to tease out, because if I do, mechanical exam on the jaw and the jaw is moving well, I can open, close, protrude, retrude, laterally deviate, you're not seeing anything there, then that's one feature that stands out and probably referring maybe from anterior neck. Here, history of unilateral neck pain, it's not really giving me anterior posterior. If I had anterior neck pain, jaw pain, temporal headache, that would be enough there to kind of make me want to pause and maybe how aggressive I am. If this individual really didn't show any signs of, I'm guessing, of any other cardinal signs, they did gentle mobilizations, which is, maybe where you want to be with this individual if you're going to do any manual work with them then. Following day developed ipsilateral ptosis and blood pressure was unusually high. So again, certainly, drooping of the eyelid, any ocular changes, that's going to be something that's going to be cranial nerve driven, and we're going to really look out.
In that example, though, you're not saying that the mobilizations would have caused any vascular problems when you just.
Yeah, I don't think so.
Okay.
Yeah, I don't think so. I don't think the mobilizations were the driving force, or I think it would have happened faster.
Correct.
That's where it's like, in here, as I read this, it's like, yeah, with the pain, if they did an exam and, looked at cranial nerves and position testing and it was coming up negative, then a gentle grade 2, grade 3 mob, if you have a small, dissection and a clot sitting there, possibly you could move it. But quite honestly, it shows that active range of motion creates just as much stretch on the cranial nerves and the motions as many of the joint techniques we do. so that, rotation and extension is going to put a lot more torque on the vertebral nerve artery. It's usually up around C1, C2 is where that tension is. It's usually a contralateral one. But, if you have an osteophyte that's in the canal from the vertebral joint, you get something like that going on, then you have these anomalies in the neck, which could drive it. 42-year-old wouldn't necessarily expect that to be the case. It's probably more of a dissection, as I would think, that, you get this dissection where you get this neck jaw pain, but you haven't had basically a clot thrown. So he threw a clot the next day, but I don't know that. I wouldn't think that the mobilization would have driven that. Oftentimes when they get it, it's like your symptoms start getting worse. You hear those chiropractic studies, and I'll pull one or two of those if you want, just to kind of see what they read and how they present. It's usually afterward. It's right afterward they were dizzy, they felt off, they got progressively worse. And oftentimes I don't think it's terribly delayed. There's an acute change that happens, and it gets worse. And again, here, the key differentiator here was the ptosis that went in dramatic blood pressure response as a result of the vascular insult. But there wasn't any real, in that case, I think, pre-warning for it. So this whole document is in your reading section. I know it's super fun reading. It's very exciting to do. But what's nice about it is I thought it was a very succinct document to kind of go through and say, here's what we do. There's plenty out there. I think even, I don't know if I put it in the fellowship readings. Sometimes I'll put in articles that contradict each other because it's nice to see different opinions. To not agree with somebody, I really feel like I need to understand their opinion before I blanketly disagree with it. So I'll read people who may give contrary opinions, those that will project that you shouldn't do any type of VBI testing because it doesn't really matter. It makes you feel, safe when you really shouldn't be safe, but it's not going to really change what I'm going to do per se. So having a system and looking deeper is important, even if it's, making you decide to do nothing for somebody you could have done something for. And the knowledge too, that terrible things happen and they're random. But if it does happen to you, if you felt like, I did everything I could that was reasonable ahead of time, and whatever happened fluky, you want to be a good practitioner. So knowing that, okay, I have a system here which is about as good as I can get to do this. You have it in place for that individual who, I want to manipulate them, but they have a couple of these factors in here I want to account for. So looking at these things is just really, really helpful. And that's where we're going to spend our time. That's why, the cranial nerve section is in there. We're going to look at cranial nerve section with position testing as we basically look at extension, rotation, combining motions within there. And there's going to be some dizziness differentiation tests we'll do too, because we want to kind of at times, again, nothing's perfect, but we want to be able to differentiate, okay, can I determine if this is cervigenic dizziness from vertiginous dizziness? So in this section, like right underneath that area, we're going to go through and we're going to take a look at this. I want to emphasize too is that doing this really well and understanding this portion of it is also very helpful if you think, okay, what if we're seeing concussion patients? Because you need to have this differentiation because your VOMs are ocular tests, your eye tracking tests. So understanding the role of the ocular muscles, how they're controlled, is this a central or is this kind of a peripheral problem? Is very helpful. So in those individuals, yeah, you're going to stimulate dizziness and headache and symptoms, but it's from central integration problem. They won't necessarily have a motor tracking problem. They will have a sensory integration problem. So if, as we're doing this, you also think about, okay, having this test clean, we're looking for, do they have a cranial nerve defect? And do I see it in multiple levels? But as we apply to our other patient caseloads, what we see by having the familiarity with these testing, we can kind of take a look and say, okay, I can stimulate this person's symptoms who's post-concussive syndrome with mechanical stimulation of the neck. Their dizziness is cervigenic. They firm that cervical bucket. If I'm doing the eye tracking and I got no vestibular input and they're getting dizzy, do I have an ocular motor integration? So it's an ocular motor situation driven. That's where the VOMS test kind of came in, looking at eye tracking movements to see, if I look at the eye tracking and if I reproduce symptoms, this person probably has a vestibular ocular integration problem. There certainly can be some vestibular ones. So as we get down layer, you may say like, oh, I can really kind of take this information and this assessment, and yeah, we're doing it for cervical manipulation, but hey, in module 6, maybe now we take the skill and we see that, hey, the skill set I'm building here goes across populations. It may be looking at seniors and taking a look at this and saying, hey, listen, this senior, many times with balance and these integration problems, it goes to peripheral and central vision delineation and telling those things. Now, this isn't part of this assessment, but it's certainly what they see with kind of long COVID. These vestibular ocular, these integration problems can be one of the drivers with long COVID, certainly post-concussive patients. And you'll see some overlap with senior balance strategies as well. So I just want you to think that this is going to be, okay, well, low risk, most people don't have it, probably never going to see a VBI, don't need this skill set. If you have this skill set, you're going to quickly be able to go across patient populations from, hey, maybe it's the senior, maybe it's somebody with long COVID who's had problems with integration, maybe it's the post-concussive patient who's subacute, or maybe it's that post-concussive patient you see 2 or 3 years later, which really just hasn't brought it all together. And that's where we'll get into some of the exercise portions of it if we have time. Woo! So my goal was hopefully not to make that as incredibly boring as some of these things can be. And you have this IFOMPT paper. It's good. It's a nice thing to cover. Jim's presentations do a nice job. When we get to the course, we'll be looking at cranial nerve review. When we get to this section on Saturday morning, we will be going over kind of the progressive testing that's in there. So we will cover this there. This is really important as far as the curriculum. The people who train me, Gail, Fred, Jim, is like really emphasizing this portion of it in detail. It's always a high emphasis. But again, we have the ability to deliver it via Zoom, online, and there. So we get this time together in lab. I try to focus the lab on what can I do with you there that cannot be done in another forum. So that's kind of why I wanted to take this time to kind of spend it here instead of waking you up Saturday morning, with an hour of this thing. So hopefully this is helpful. You have it recorded. You have the IFOMPT document, which is kind of a nice resource to kind of go to. Cool. Any comments, questions, statements?
Dave, if you have a couple minutes after, I just have a couple questions about this weekend, and then if you could post last week's Zoom session, because I was out of town.
Okay, I will. Sometimes it's easy. I'll stop